The second young physician to present today is Dr. N.S. Sathiruban, Senior Registrar in Respiratory Medicine, National Hospital for Respiratory Disease, Balisara. He'll be talking to us tuberculosis in special situations.
Calling Ceylon College of Physicians for this opportunity. I am today presenting in tuberculosis in special situations. Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis that mainly affects the lungs but can involve any body parts except hair and nails. It is occasionally caused by Mycobacterium bovis and Mycobacterium africanus. Tuberculosis spreads through respiratory droplets when a pulmonary TB patient coughs or sneezes or laughs. The bacilli are expelled as droplets, which may suspend in the air for several hours, if not clear or dilute by the fresh air. When we go to the tuberculosis pathogenesis, the primary infection occurs on first exposure of a person to the tubercle bacilli. And once the tubercle bacilli enter the respiratory tract through the inhalation, organisms reach the alveoli of the lungs, where they are engulfed by the macrophages and presented to lymphocytes. This leads to an immune reaction against Mycobacterium tuberculosis, which results in subpleural gonfocus with enlargement of the draining lymph nodes 4 to 6 weeks after the primary infection. In a few cases, primary infection progresses and leads to complications of primary infection. Approximately 10% of people infected with bacillus but not suffered from any other concomitant immunosuppressive conditions will develop the active disease during their lifetime. Gonfocus and the enlarged draining nodes comprise the primary complex. In most cases, the immune response is sufficient to stop the multiplication of the bacilli and to prevent the development of the disease. The primary lesion may heal by fibrosis or by calcification. A positive tuberculin skin test may be the only evidence here. This is the picture of the gonfocus and gon complex. And there's a granuloma that's surrounded by the multinucleated giant cells, and there's a central caseous necrosis. And when we consider the treatment of tuberculosis, the modern treatment strategy is based on standardized short course chemotherapy regimes and proper case management to ensure completion of treatment and cure. When we consider the aims of treatment of tuberculosis, to cure the patient of TB, to prevent death from active tuberculosis and its late effects, and to prevent relapse of tuberculosis, to decrease the transmission of tuberculosis in the community, and finally, prevent emergence of drug-resistant tuberculosis. We are normally used for the drug-sensitive tuberculosis. We are using the 4 first-line anti-TB drugs. As we all know, isoniazid, rifampicin, pyrazinamide, and ethambutol, and we are using the new and retreatment phases and 2 phases, intensive and continuation phase. These are the dosage of the drugs and minimum and maximum dosage. When we consider the isoniazid, it is a potent drug exerting early bactericidal activity. It prevents emergence of drug-resistant mutants to any companion drug and low rates of adverse drug reactions as well. And rifampicin, it is a potent bactericidal and sterilizing drug acting on extracellular semi-dormant bacilli, which multiply intermittently and cause relapses. Pyrazinamide is a bactericidal and sterilizing drug, effective in eliminating intracellular semi-dormant bacilli multiplying slowly in an acidic environment, thus reducing the relapse rate as well. The ethambutol, it is also effective but bacteriostatic and helpful in preventing emergence of resistance to other companion drugs. When we consider the role of intensive phase, it helps to rapid killing of actively multiplying bacillary population and eliminate naturally occurring drug-resistant mutants, prevent the further emergence of drug-resistant mutants, and optimal minimum duration of 2 months in new cases is essential for achieving smear conversion 90% and above, and thereby significantly reducing the infectiousness of the patient. And we are using for the new cases 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, and retreatment cases 3 months of HRCT. And when we consider the role of continuation phase, it helps to eliminate the persisters and those bacilli that were initially dormant but activate after some time, which are responsible for relapses. The optimum duration in new patients are 4 months of isoniazid and rifampicin, and retreatment phase 5 months of isoniazid, rifampicin, and ethambutol. The retreatment category, the CAT2, we are using that word, and it includes the patients previously treated cases without drug resistance, relapses, treatment after failure, and treatment after loss to follow, and other previously treated cases. TB treatment in special circumstances, that's my topic. Though the basic principles of management of tuberculosis remain the same, there are certain special situations in which regime must be modified. In all cases of special situations, consultant respiratory physician and experts of respective specialty should be consulted at the time of initiation of tuberculosis treatment and reviewed jointly on monthly basis during the treatment or as advised by experts. We today see about the special circumstances: pregnancy, lactation, TB in neonates, TB in diabetes, TB in renal insufficiency, HIV and TB, and pre-existing liver impairment and TB in elderly, tuberculosis in pre-existing skin disease, hypoadrenalism, gastritis, and fever and thrombocytopenia in tuberculosis patient. My first case is 29-year-old woman, presented at 34 weeks of gestation, presented with cough for 5 weeks, weight loss, fever, and night sweat, and denied any contact with tuberculosis. And sputum AFP and gene experts suggest presence of Mycobacterium tuberculosis without rifampicin resistance. When we consider the risks of maternal TB, the spontaneous abortion, perinatal mortality, small size for gestational age, and low birth weight outcomes is unfavorably influenced by delays in diagnosis or treatment. When we consider the effect of pregnancy on TB, the immune mechanism, the balance of T helper 1 and T helper 2 ratio is altered during the period of pregnancy, and TH1 TH2 ratio is reduced during the pregnancy, thus potentially increasing susceptibility to new infection and reactivation of tuberculosis. In the early postpartum period, TH1 suppression may be reversed. This may be associated with exacerbation of symptoms. The guidelines for X-ray examination or exposure during pregnancy, a single diagnostic procedure does not result in harmful fetal effects because the radiation dose is less than 5. And concern about possible effects of high-dose ionizing radiation exposure should not prevent medically indicated diagnostic X-ray procedures. Ultrasonography and MRI are not associated with known adverse fetal effects. Tuberculosis in pregnancy, so do chest X-ray whenever necessary. Other investigations, sputum for AFP 2 to 3 samples, and sputum culture for fast bacilli. The treatment during pregnancy should be started as soon as diagnosis was made, and we have to give the full course of treatment, and basic principles of treatment not differ, and most anti-TBs are safe to use during the pregnancy. When we consider that TB treatment in pregnancy should take pyridoxine 10 mg daily with isoniazid to prevent the peripheral neuropathy, and neonates born to mothers on rifampicin should be administered vitamin K at birth to prevent the risk of postnatal hemorrhage. Then TB in lactating mothers should receive the full course of anti-TB treatment, and proper treatment is the best way of preventing the transmission of TB to the baby. And all anti-TB drugs are compatible with breastfeeding, and breastfeeding can be continued in the normal manner while the mother is taking anti-TB treatment. And recently diagnosed smear-positive mothers should be advised to wear face mask during breastfeeding and avoid coughing onto infant's face. And they should breastfeed in an adequately ventilated place and minimize sharing common breathing space with the infants. And TB, HIV co-infection mothers, the venerologist opinion prior to initiate breastfeeding is needed. However, breastfeeding is usually not promoted in TB, HIV co-infection. And management of newborn child of a mother with active TB, don't separate the child from the mother unless she is acutely ill. If the mother is sputum smear negative and if the infant has no evidence of congenital TB, BCG is given to the infant. If the mother is sputum smear positive at the time of delivery, infant should be carefully examined for evidence of active disease. If the infant is ill at birth and congenital TB is suspected, a full course of anti-TB treatment should be given. The newborn to mother with TB, if the child is well, give prophylactic treatment of isoniazid 10 mg per kilogram daily for 3 months and BCG is withheld. The MAR2 test is done after 3 months. If the MAR2 test is negative and the child is well, prophylactic treatment with isoniazid is stopped and child is given BCG. If the MAR2 is positive, careful examination of the child of active TB is done, including chest X-ray. If MAR2 positive newborn, if active disease is diagnosed, a full course of anti-TB treatment should be commenced. If the physical examination and the chest X-ray are normal, isoniazid chemoprophylaxis is continued up to 6 months. My second case is 62-year-old diabetes patient presented with chronic cough, loss of weight, evening pyrexia, and night sweats without any history or contact history of tuberculosis. His sputum AFB was positive 2 times, and gene expert detected moderate amount of mycobacterium tuberculosis without rifampicin resistance. Chest X-ray, there's a right upper zone cavitating lesion, and TB culture mycobacterium tuberculosis isolated and drug sensitivity test sensitive to all first-line anti-TB drugs, and pyogenic culture and fungal culture, there's no growth. This is a TB patient with diabetes. The patients with diabetes are more vulnerable to develop tuberculosis, and TB and diabetes comorbidity make each other worse. And studies have shown that there is increased morbidity and mortality in patients who have tuberculosis, diabetes comorbidity. Early diagnosis of tuberculosis in diabetes and the exclusion of diabetes and proper control of diabetes in patients with tuberculosis is important to improve outcome of tuberculosis treatment. And treatment of TB as same as the non-diabetic patients and important to assess the renal function in diabetic patients. If there is a renal insufficiency, the isoniazid rifampicin elimination is from the biliary excretion, then there is no need of dose adjustment. But ethambutol and metabolite of pyrazinamide is renally excreted. So in the stage 4 and stage 5 chronic kidney disease, the 3 times per week ethambutol and pyrazinamide doses were used. And isoniazid should combine with redoxin to prevent the peripheral neuropathy. The pyrazinamide and ethambutol, in the dialysis patients, we are using 2 strategies, the pre-dialysis strategy and the post-dialysis strategy. Choice of the strategy influenced by the ensure adherence, practical issues, expected pharmacokinetics, and drug interactions. Ensure adherence post-dialysis offers the opportunity for the directly observed therapy, and post-dialysis avoid premature drug removal but possible risk of raised drug level and drug toxicity between dialysis sessions. But in the pre-dialysis strategy, the 4 to 6 hours before dialysis, and it increases the premature drug removal but reduces the drug toxicity. When we consider the renal transplant patients with TB, rifampicin interact with the immunosuppressive agents and increase the graft rejection, and mycophenolate mofetil, cyclosporin, tacrolimus may need adjustment, and corticosteroid doses should be doubled. My third case is 40-year-old male, recently diagnosed as retroviral infection, came to the clinic for TB screening, found to have cavitating lesion in the chest X-ray. Smear is negative and MAR2 negative, but gene expert mycobacterium tuberculosis isolated, i.e. without rifampicin resistance, and TB culture is pending. In this patient tuberculosis, the bacteriologically confirmed tuberculosis with HIV. HIV is the most potent factor known to increase the risk of progression of latent TB to tuberculosis disease. Tuberculosis usually occurs earlier in the course of HIV infection than other opportunistic infections, but may occur at any stage. Among HIV infected people, TB infection results in transient drop of CD4 counts and progression of HIV infection. And there are many cases with disseminated and extrapulmonary TB common in the TB HIV infection. The diagnosis of tuberculosis in HIV patients often difficult. Smears are mainly negative more often and especially in the later stages. And X-ray abnormalities are atypical and MAR2 negative due to immunosuppression. And GeneXpert is the only initial diagnostic test, and culture 2 samples can be done. And tissue biopsy aspiration from suspected extrapulmonary sites, cytology, histology, and direct smear and culture we have to do. And TB in HIV early stage, CD4 counts more than 350, resembles post-primary pulmonary TB. It occurs after a latent period of months or years after the primary infection. It may occur either by endogenous reactivation of latent primary infection or by exogenous reinfection with tuberculosis bacillus. Site of the post-primary TB is usually the lungs and results in lung cavitations, fibrosis, patchy consultations. They are the patients who become sputum positive. But in TB in HIV late stage, CD4 counts less than 350, resembles primary TB, and sputum smear often negative, chest X-ray often infiltrates, lymphadenopathy, pleural effusion, extrapulmonary TB often presents, and primary infection progresses and leads to complications of primary infection such as pleural effusion, biliary TB, TB meningitis as early complications, and bone TB and renal TB as late complications. In TB HIV co-infection, priority is to treat tuberculosis. Current WHO guidelines recommend that tuberculosis treatment should be commenced first, and antiretroviral therapy commenced subsequently as soon as possible within the first 8 weeks of starting anti-TB treatment. In case of severe immunosuppression, CD4 less than 50, and in very ill patients, antiretroviral therapy should be commenced within 2 weeks. And generally, anti-TB treatment in HIV positive patients is same as for that of HIV negative TB patients. Adverse reactions to anti-TB drugs are more common in HIV positive patients, and drug interactions occur between anti-TB and antiretroviral therapy. It is important that those patients should receive directly observed treatment dots. To maintain the confidentiality of the HIV status need not be divulged to the dot provider. Effective treatment using quality drugs under observation can cure tuberculosis and prevent the spread of the disease and prolong the life of HIV patients. When we consider the immune reconstitution inflammatory syndrome, the paradoxical exacerbation of symptoms, signs, and radiographic manifestations of tuberculosis may be seen in patients on anti-TB drug when they are started on antiretroviral drugs. When we start the early antiretroviral, there is a risk for high risk, but when we delay it, there is a risk of HIV disease progression. The rate of recurrence of TB after completion of treatment is higher in HIV positive patients than in HIV negative TB patients. The case fatality rate high in HIV positive TB and TB itself or HIV related problems. When we considering the high rates of morbidity and mortality in case of co-infection, all HIV positive cases should undergo expert mycobacterial tuberculosis GeneXpert for detection of TB disease as well as resistance to rifampicin on relevant biological specimens. The next special situation is the TB and the pre-existing liver disease. The serum bilirubin ALT should be done on all patients as a routine baseline investigation. If pre-treatment serum bilirubin and ALT are abnormal, such patients should be managed as anti-TB induced hepatitis. If patient symptomatic and liver functions more than 3 times upper limit of normal, need to stop the anti-TB treatment. And if asymptomatic more than 5 times of upper limit of normal of liver functions, need to be withheld anti-TB treatment. If patient ill or extensive lung disease, bridging treatment is preferable until liver function is normal. If both bilirubin and ALT high, we have to bridge with the either amikacin or streptomycin plus levofloxacin or ofloxacin plus ethambutol. If bilirubin only high, we can use the isoniazid as well. Isoniazid levofloxacin ethambutol or isoniazid ethambutol amikacin or isoniazid ethambutol streptomycin bridging. After liver function normalized, challenge with the isoniazid rifampicin and the pyrazinamide. This is the child score. According to the child score, if patient is in child A, 2 hepatotoxic drugs can be used, namely isoniazid and rifampicin with or without pyrazinamide, and duration 6 to 9 months. In the child score B, ideally 1 hepatotoxic drug, and child score C, no hepatotoxic drugs to be used, can use second line drugs such as streptomycin, ethambutol, fluoroquinolones, and amikacin. Those things. Then other special situation is tuberculosis in elderly. The elderly is presented mainly as a atypical presentation. They confused with the age-related diseases and prolonged cough, loss of weight, loss of appetite, hemoptysis, evening pyrexia, and organ-specific symptoms are main presentations. The delayed presentation is mainly due to the dependency of the elderly or socio-economic reasons and more prone to adverse drug reactions as well. And when we consider tuberculosis with pre-existing skin disease, skin reaction is more common with ethambutol, is more common with skin reaction than the pyrazinamide, than rifampicin and isoniazid. And so we need dermatologist input for pre-existing versus drug-induced cutaneous reaction. If only itching, no need to stop the anti-TB treatment. We can manage with the symptomatic treatment with antihistamines. And TB with skin disease, if rash with itching, we have to stop until the condition is treated or recovered from the cutaneous reaction. And check for serum bilirubin and full liver profile, blood urea. And if anti-TB induced cutaneous reaction, we have to challenge the dose from the least toxic one to toxic one. And scabies, ichthyosis due to chronic disease and malnutrition can mimic the TB with skin disease. And other condition is TB in hypoadrenalism, patient presented with fatigability, hypotension, and hypoglycemia as Addisonian crisis. And it's mainly due to the TB adrenalitis or rifampicin-induced adrenal crisis. So we need hormone replacement with hydrocortisone, and rifampicin increases the cortisol metabolism, clearance, and can trigger an adrenal crisis in patients with pre-existing adrenal insufficiency. And rifampicin-induced gastritis, the night dose of rifampicin is suggested in these patients with individual drugs, and symptomatic treatment with the antacid and proton pump inhibitors and antiemetics, and need to exclude other causes with the gastroenterology input and upper GI endoscopy. And fever with thrombocytopenia, TB itself can cause the fever with thrombocytopenia because of the bone marrow involvement or myelosuppression or TB itself. And the other thing is anti-TB drug-induced fever with thrombocytopenia. Also, there are reports are reported with rifampicin. But other thing is we have to exclude the other causes such as infection, malignancy, inflammation, and medication-induced fever and thrombocytopenia. My special thanks to my trainer, Dr. Bandhu Gunasena sir and Vatsala madam. Thank you.
Thank you. And it's open for discussion or any questions from the audience.
Thank you for the comprehensive presentation. Just a question on the in HIV patients, is rifampicin resistance found more than in other categories, or is it about the same?
It's more in the HIV patients.
As a percentage, like what you
multi-drug resistant TB is common in the HIV patient. It is nearly 50% of patients are with the drug-resistant in HIV.
Management strategies we will employ different
We
approaches or
consider when we found the multi-drug resistant TB, then we have to start the second line anti-TB drugs. Before that, we have to do the extended gene expert to find the fluoroquinolone resistance. Then we can start the type A, type B, and type C drugs with the linezolid regime or ethionamide regime. We have to start that.
when you combine steroids in treatment from these categories, are there indications for
The steroids are mainly indicated in the TB meningitis, CNS TB. We have to treat it with the dexamethasone or prednisolone. And the other thing is, if patient with the spinal TB, then patient presented with any spinal compression features, we have to start the steroids. And other thing is pericardial TB also, we have to suggest steroids treatment. And immunoreconstitution inflammatory syndrome also, steroids can be used.
So they are still individual actually, TB pregnancy, which is the common pulmonary or extra pulmonary. They reported
even in pregnancy, pulmonary TB is common, because if the extrapulmonary TB, if about the pulmonary, then we have considered as the pulmonary TB. So the cases of pulmonary TB are more common than the extrapulmonary TB.
Thank you, Dr. Sathirban. And absent any further questions, I would like to hand you over the certificate of appreciation from the College of Physicians.